Thanks so much, Dr. Bales, and thanks to the SSG for this opportunity to speak. So these are my disclosures, nothing that's really relevant to this talk. Of note, though, there are a few photographs from NICO, BK Medical, and Brain Lab that are in the talk. So over this short bit of time, I was hoping to go over four things. A little brief history of visualization systems in cranial neurosurgery, just because it's relevant to some of these retractor systems. A case illustration that's actually active at this moment. It's a patient of mine currently at Johns Hopkins Hospital. And I think it illustrates the benefit of some of these tubular retractor systems, especially in cases where something like a stereotactic biopsy has failed before. The meat of the talk is still pretty short, but it's going to be a case series of our experience at Johns Hopkins Hospital using these tubular retractors for primarily for deep-seated brain tumors, as well as for some ICH. And then some thoughts on future directions, particularly as related to ultrasonography and ways that we could potentially work together to gather more information that's meaningful to these patients moving forward. So with that, the brief history of visualization systems is actually not that brief. If you look back at ancient Rome in the top left, there's a schematic of the types of retractors that surgeons used at that time, including those that did cranial procedures. Dr. Krauss used a very large frontal lobe retractor, as you can see in the middle image there. And I think because of some of the concerns at that time and since with regard to brain retraction, led to more delicate and more precise brain retractors, including Fraser's brain retractor, which was prominent in the early 20th century. As we moved into the latter part of the 20th century, we augmented some of those retractor systems with intraoperative imaging, as we're doing more so nowadays. So I'm going to point out the right-sided screen here for those who are looking. Oops. Maybe not. And so what this is actually showing is an intraoperative ultrasound that was done on a patient of Dr. Michael Reed, who was a neurosurgeon at UCSD. And it was the first use of intraoperative ultrasound in neurosurgery that at least was documented in the literature. And so what this is showing is the surface of the spinal cord and an intraoperative cystic astrocytoma within it. The reason that's relevant, I think, is as I and others start to use and continue to use intraoperative ultrasound as an adjunct to our tubular retractor systems, a lot of what we do now really harkens back to our past. And one of the largest series in the latter part of the 20th century was Dr. Patrick Kelly's series using a stereotactic retractor at Mayo Clinic. So he reported a series of 123 patients where he used this system that had a stereotactic guide to it and a metallic retractor that would go in. And he really did some amazing cases. This was a near total resection of a thalamic glioma using his retractor system. And so from there, a lot of training has been historically, how to optimize our retractors and our systems. I think in the last 15 to 20 years, there's been more and more thought about trying to avoid actually retractors, particularly using the cisterns and the skull base and normal fissures. And Dr. Spetzler actually had a notable commentary in the Journal of Neurosurgery about 10 years ago, which is where that picture comes from here. One of the more prominent early examples of using these tubular retractors actually came out of Johns Hopkins. And so the pictures on the right are from a paper by Dr. Pablo Recinos, Violette Renard Recinos, and Dr. George Jallo. It was a series of 4 patients that had deep-seated brain tumors, and what was then called a view site retractor was used, as you can see here, to obtain good resections on those patients. And it was one of the earlier series using these tubular retractors that we've become so familiar with. I think as you look through the literature, I think there is a learning curve, and that follows the learning curve that we at Hopkins and I personally have had over time. So some early experiences were related to biopsies. So this is a series out of Cornell from Ted Schwartz and his group, where the majority of these patients had supratentorial lesions. The majority of them were gliomas or lymphomas, and the majority of these patients underwent tubular retractor surgery, frankly, just for biopsies, where prior patients had failed stereotactic biopsies, and they really showed excellent outcomes, no hemorrhages, and 100% diagnosis rate. And with that, I think others in the field continue to become more emboldened to use these retractor systems. And just like I moved from using biopsies to then trying to attack larger lesions, it's often the first thing we'll do is use these retractor systems for superficial lesions. So Dr. Shermer and his group at Geisinger published their series on cavernous malformations and using some of these retractor systems. It was a relatively small series of 6 patients. And as you can see from their imaging, there were pretty superficial lesions. And they're lesions that are superficial enough that honestly, in the more recent literature, they probably wouldn't count as deep-seated lesions, but nevertheless, it's these kinds of experiences that allow us to feel comfortable as we approach deeper and deeper lesions. Another example of moving along that learning curve is from Dr. Schwartz's group. And so years after his initial biopsy report, he had a series of 10 patients that underwent tubular retractor removal of deep-seated brain lesions, with an example over here on the right. I think patient selection, Dr. Schwartz will always say, is exceedingly important when learning, when moving along your learning curve. And I think, he got a gross total resection on all of these patients, only had one transient deficit, and the operative time was remarkably low, I would say, especially for some of these deep lesions. I should mention that there is, a number of groups across the country that have really been leaders in the field. The first few papers are from the folks at Mayo, Florida, where they did subset analyses of different tumor types for which they use these retractors, including high-grade gliomas, brain metastases, and even operating in the posterior fossa. Aside from our group in the pediatric realm, the group in Seoul, South Korea, also had a quite large series more than 10 years ago. And the group at University of Miami has been very busy with regard to using these deep-seated retractors as well. And so with all of that data in the literature, that's helped me as a relatively young attending feel comfortable trying to use some of these newer techniques. And so for these next couple pieces, I'd like to go through a case illustration and then our case series, including my cases in the first few years of practice. So just a few weeks ago, this patient presented to Johns Hopkins Hospital in our ER. She was a 21-year-old hirsute African-American female. She had a history of VSD repair on her heart at about 9 months of age. And she presented with months of new headaches that were pretty diffuse, new left V2 facial numbness for a few weeks, and gradual left eye vision loss over 3 weeks, to the point that she was actually blind in her left eye when she came to the hospital. This is a picture of her right optic nerve showing the pallor and papilledema. And here are her visual fields, where she has no vision on the left and pretty close to no vision on the right. Unfortunately, before she came to us, she was given steroids at urgent care. And so though this was her imaging, we tried to find if there was another source at all anywhere in her body. And aside from, I think, an incidental left-sided sphenoid sinus mucocele, everything was negative. We didn't feel comfortable putting in or getting a lumbar puncture, a high-volume lumbar puncture, because of the mass effect in the brain. Diamox was started as a temporizing measure. Optic nerve sheath fenestration was deemed not an option by our ophthalmologist. And so a stereotactic biopsy was performed, but again, she had recently been on steroids. So these are our screenshots. The first is from my first position. So we're in the lesion, but again, it's whether it's not as much enhancing, whether that's because of the tumor itself or because of the recent steroids, hard to know. I actually took 5 frozen specimens, 3 at the superficial layer, and then a couple deeper. The second path was consistent with atypical cells, and thus, given that I didn't think taking a 6th and 7th specimen were frankly safe, we closed. But with some hope that, given its gross abnormal appearance and atypical cells, that we would get an answer. She was discharged, clinically stable until about 10 days post-op, where she had worsening vision, somnolence, and recurrent headaches. And her imaging around the time of discharge is on the left, and at the time of recurrence, or at the time of representation, is on the right. Given that we, re-imaged her again, she had nothing else aside from this lesion. We did take her to surgery, and Einstein said to do the same thing over and over again and expect a different outcome is madness. So we didn't do a stereotactic biopsy, but we did do a mini craniotomy for our retractor system. This is our usual setup. So for a right-sided mini craniotomy, we would have our image guidance on the left with the short arms of the brain lab towards us to give us a little bit more operative room. We do put our retractor away from, we put our cerebellar away from our primary retractor system. And we usually have a C-arm followed by a universal and two straight bars. Importantly, we have our shepherd's hook not parallel to the cerebellar, not perpendicular, because when it's perpendicular, it tends to get in the way a little bit. We do use intraoperative ultrasound using this intraoperative ultrasound probe. We will be getting a new probe that has some more features to it, and that I'll talk a little bit about in future directions. But you can see there's normal parenchyma to the left, normal parenchyma to the right, and lesional hyperechoic material just below where we were. Which, especially given that we had to put this young person through another procedure, it's a nice verification tool to provide real-time data. This is a sense of a couple pictures from intraoperative. Historically, I think people have used an exoscope for these tubular retractors, but at least the ergonomics for me have been a little bit off. And I think the room is generally a little bit more attuned, including our support staff, to having a microscope. So we've transitioned to using a microscope. So within the retractor system, there's normal parenchyma over to the right, and there's abnormal looking tissue over to the left. Some people would use a NICO device. I think for biopsies, I tend to just use a suction and a bipolar and a pituitary instrument, which you're seeing here. But I think a NICO is an excellent instrument as well, and actually, might allow you to save some tissue for research, as people have talked about in the last day or so. And here's our resection cavity from what we initially took. So, we did have tumor consistent with lymphoma. We're awaiting flow results. She's on some steroids now at full blast and awaiting a final treatment plan. Of note, we get this clinical data. I'm a health services researcher as well, and so I'm sort of interested in these kinds of things. For our stereotactic biopsy, it took twice as long, frankly, than a normal case would take, just because of all that time waiting for pathology, as opposed to using a retractor system and a mini craniotomy actually saved time relative to our relative to our stereotactic biopsy. Briefly, I'd like to just go over our case series just as another set of data points in the literature. And so from 2016 to 2022, 5 surgeons at Johns Hopkins, including myself, Chris Jackson, Judy Huang, Chetan Bedagauda, and Mike Lim, who's currently at Stanford, used a brain path or tubular retractor system on 49 patients, mostly for deep-seated brain tumors. And I should also mention the first author is Maureen Rakovic, who is a really outstanding neurosurgery resident at University of Maryland. So focusing on the tumor subset, we had 43 patients who had deep-seated brain tumors. The majority of them were glioblastoma or high-grade gliomas and primary CNS lymphoma, and that's primarily what this is demonstrating. I think in the take-home points from that tumor subset is that about, and again, this is for folks that are relatively early in their learning, including myself. We had a gross total resection rate of about 81%, when the goal of surgery was resection, not just biopsy. For those where biopsy was the goal, we achieved a diagnosis 90% of the time. There was one patient where multiple attempts were made at biopsy, and the primary surgeon thought that it was best to stop and potentially bring them back, and they found a diagnosis through other means. There was some rate of post-op hematoma, as opposed to what you'll sometimes see in the literature of rates of 0. So we weren't exactly 0, but pretty close at 7%. But none of those patients needed to be taken back to the operating room, and all were none had deficits, and all were managed medically. And favorable discharge, meaning home or rehab, was possible for 95% of patients, which I think again speaks to patient selection. In terms of future directions in this last minute, I think a few things. If you look back over the last 15, 20 years, historically, we've used image guidance systems that are linked to our navigation through physical add-ons to our ultrasound or image guidance system to help guide us in surgery. I think there are new systems that seem exciting and interesting, where between the ultrasound and, say, for instance, a brain lab device, you can have more real-time updates to account for brain shift and particularly get account of where you are for deeper tumors. I think at Johns Hopkins, this is the work of Ryan Lee and Mark Luciano. There's a lot of interest in looking at ultrasound and looking through clear cranial implants to try and get a sense of ventricular size and tumor growth over time. And I think coupled with a lot of these retractor systems, there's a lot of promise in the future. And one final point that I would say, and this is a little bit of a pitch to this group, I'm involved in the quality outcomes database, particularly in the tumor subset. Last year, a paper was published where we talked about our initial series in the QOD, where we've captured, it was more than 1,000 patients that have various tumors, including deep-seated gliomas and brain mets using CPT codes. The interesting bits, I think, to that, aside from just the usual outcomes that we have, are that we have, very practical outcomes related to return to work and quality of life as measured by the Promise 29 quality of life instrument. I'm not going to go through this in detail just because of time, but more than 1,000 patients collected in 6 months from more than 20 sites across the country. None of them are specifically looking at tubular retractor and deep-seated lesions, but it's definitely an opportunity for us to collaborate for those who are interested. We capture complications that are of interest to us, including hemorrhages, reoperations, and readmissions, including these quality of life metrics. So hopefully with that collaboration between the group and between us, we'll be able to move forward in a quality focused way for these patients. So that's what we talked about, and thanks so much for your time.
Thanks, Raj. Great talk. And I think you characterized yourself as a relatively young neurosurgeon, but that's an advanced case series and advanced use of technology. If we had you back in 3 years, what do you think you would be contrasting your technique or your approach at that time? What do you see on the immediate horizon?
Yeah, I think there's a lot of opportunity for intraoperative adjuncts, and whether that is with intraoperative fluorescence or intraoperative ultrasound, to actually have real-time feedback. I think historically, we use these static images from before surgery, and we try our best to approximate things in surgery. And I think whether it's with ultrasound or things like 5-ALA, I think that'll help us as surgeons be a lot more efficient. And I think in terms of the basic science side of things, that's a little bit out of my realm, but I would imagine that with these systems that we've heard about in terms of collecting tissue on these patients, we'll learn a lot more through, say, single cell RNA sequencing and through a lot of smart people in this room that will help us understand the biology of these tumors as they progress over time.
Yeah, sounds good. Thank you.
Thanks.